Hi everyone, welcome to our Cam Live this evening. Hope you're all well. I'm Nikki, and this evening really happy to introduce or reintroduce Simon, who's been on before with Hannah. He has come this evening to talk about a massive topic, and it's something that comes up a lot on Holly's Army. And when I was looking through Holly's Army to sort of prepare a little bit for this and look at the types of things that people ask around arthritis and dogs with concurrent disease, so with kidney disease or liver disease, there are sort of millions of questions that come up and concerns, and it is a concern, and it does make life more difficult when you're dealing with more than one disease. But hopefully we're going to clear up some of those issues this evening. If anyone does have any questions that they want to ask as we go through. Hi Luke, see you already there. Luke was the person I was talking about earlier that was messaging about the kidney values and what to do about them earlier on in the week. So yeah, hopefully Luke, we're going to answer some of your questions. I am going to pass over to Simon to introduce himself, because he can do it a lot better than I will be able to, and then we will start chatting. Simon, welcome. Thank you so much for coming. Would you like to introduce yourself, please?
Yeah, no, of course. Thank you for inviting me. No, it's good to be back and come to chat to you. So I'm an internal medicine specialist. I was at uni with Hannah, so that's a while ago now. Then did a stint in practice for a couple of years, and then a residency at the University of Bristol in intensive care and canine medicine. And then I've been at Dick White Referrals for the last 15 years, where I've mainly been a consultant in internal medicine, head of internal medicine, and now I'm clinical director. So hopefully fairly well placed to talk through internal medicine issues and how they relate to dogs.
Yeah, absolutely. So internal medicine, for those that aren't quite sure, it's all the things that go on inside. So kidney disease and liver disease are two big things, I guess, that you deal with on a daily basis, I suppose.
Yeah, I think they form a good part of our caseload. Yeah, or a concurrent diseases with other things that we're investigating.
Yeah. I mean, we'll go on to diagnosis in a minute, but what would your description or your definition of kidney disease or liver disease, just in a brief summary, how would you describe what are they?
So that could take up the rest of this hour, I guess, in terms of defining both of those.
It's a bit of a mean question.
Yeah, but I guess if we start with kidney disease first, so the kidneys, obviously the body's filters in a large extent. They get rid of proteinous waste products, so they get rid of things that shouldn't really be there, help us to regulate water balance. And we obviously have two kidneys, as do our canine friends. And over our lifespan, our little units, the little filters that are there, the nephrons, gradually get damaged and they die off. And we have a huge capacity. We have lots more than we'll ever need, but as the animals get older, we can see that a proportion of those nephrons die off. And once we get down to about 30% of that value, we can start seeing signs that the kidneys aren't able to do their job effectively. So they're not able to excrete things from the body in the way that we would like. And this is what we call chronic renal failure, or more correctly, chronic renal disease, or CKD, in terms of us not seeing that there's that filtration capacity that we're expecting, and those values start to rise. We see that those toxins have effects, so they make dogs feel nauseous, they start to lose weight, and there's also other effects on the body, so things like protein loss, which causes further weight loss. We can see blood pressure elevations as well, so what we call hypertension, that can cause problems. So that's kind of chronic renal disease. We can sometimes see acute renal disease as well, or acute kidney injury. And that's a slightly different thing. That's usually a reaction to some things, so a toxin or infection, so things like leptospirosis, so Lyme's disease, or heavy metal toxins, antifreeze toxicity, those sorts of things that cause the kidneys to suddenly stop working, and that can be much more difficult to treat. And usually that's where we think about things like dialysis, and that's not perhaps what we're talking about this evening when we're worried about concurrent illness. Liver disease, I guess, is another huge area, and there are lots of different types of liver disease. And we tend to break them down into different areas. So the liver, again, is another filter. It filters the blood that comes from the gut, helps us to sort of metabolize all the things that are there. So all of the building blocks for all of the growth and energy and metabolism in the body all are built by the liver. And the liver detoxifies the blood and takes out all the things that the gut produces. So there's lots of bacterial fermentation in the gut, which is great because it makes things that the body can't make. But a lot of those things do cause the body's issues if they're not filtered out of the circulation. So the liver does all of that work. And the liver diseases we see are either vascular, so things like portosystemic shunts, where some of the blood comes from the gut and ends up in the general circulation. That's usually something we see in young animals, so probably isn't relevant when we're thinking about arthritis. They can be associated with the biliary tract, so the gallbladder and outflow from the bile ducts. Again, that tends to be infection or obstructive disease, and again, probably not something that we're worried about. So the sorts of things that we think about when we're thinking about older animals where osteoarthritis may be a concurrent issue are things like chronic hepatitis, essentially chronic inflammation within the liver, within the parenchyma, or the sort of fleshy part of the liver. And a lot of those we don't fully understand. In humans, chronic hepatitis are caused by viruses, so things like Hep B, Hep C, those viral toxins that cause problems. But in dogs and cats, we don't really see those infectious hepatitis causing the chronic disease. So most of those are what we call idiopathic, which is just a long word that suggests that we don't really know what's going on.
One of my favourite words.
Yeah, exactly. It makes you sound clever when you don't know what's going on. So they cause inflammation, and that inflammation affects the liver, and over time that inflammation will cause problems, because the body's reaction to inflammation is to cause fibrosis. So we would want to try and wall off where that inflammation is, but obviously you can't do that within the liver. So that fibrous tissue forms between the sort of network of honeycomb-like cells that we have in the liver. And then that disrupts the function that the liver is able to have. And ultimately, over time, that will lead to what we call signs of liver failure. But most dogs that have chronic hepatitis actually are quite well through that, and we pick them up initially incidentally because they have elevations in liver enzymes, and we'll probably talk a little bit more about that diagnostic pathway. But at sort of early stages of chronic liver disease, animals can actually be really quite well before they get to the stages where there is irreversible damage within the liver, and that's often quite a long progression. So slowing down that progression, stopping that progression is really important in terms of what we're trying to do.
So do you feel, I mean, going back to the kidney disease, and one of the things that I'm always shocked by, and I think a lot of people are as well, is what you said, that the kidneys can kind of mask what's going on up to a point, can't they? And then they get down to that last sort of 30% of function. And then that's when we discover that there's a problem, and a lot has already happened by then. Whereas I feel like with liver disease, sometimes you get a bit more notice. Would you agree with that?
Yeah, I think that they're slightly different organs, and those diseases are happening for different reasons. So with kidney disease, the kidney can't regenerate or repair itself, whereas the liver has a massive ability to be able to do that unless the framework's damaged. And if the framework is damaged, it can't repair itself. But with quite mild insults to the liver, if you help to reduce the inflammation, actually it can repair and do quite well. So liver disease is perhaps a bit more treatable in that respect than with kidney disease, where once you do get to a lower amount of functioning nephrons, you can help and you can support them and you can slow down the damage, but you can't go back to having more kidney function. So you get perhaps a little bit more warning with liver disease that there's going to be something you can intervene with, although sometimes you do see that isn't noticed clinically, and you pick that up on blood tests or other screening tests rather than it's something that is apparent from a clinical perspective.
Yeah. So when we think about that, about the test and diagnosing disease, when we're talking about arthritic dogs in particular, it often is, I mean, you get both sides of things. So sometimes you get it where your dog is presenting with clinical signs, and so you then are doing testing to see what's going on. And then there are other times where you're just doing a screen, like you said, you pick up things when you're just doing a screen because you want to know, maybe you're going to do an anesthetic or you're going to start a particular medication, and you're just doing sort of pre-screen, and you pick up those changes then. So where would you start with diagnosing those conditions, and what things would be important for each?
So yeah, I think it is important when you're thinking about diagnosing conditions as to the reason why you're looking. So most of the time when I'm looking, we're looking because something is wrong. So with kidney disease, the sorts of signs you see are animals are starting to drink a bit more to help the kidneys to compensate, or there's some weight loss, or they're urinating a bit more because they're not able to concentrate their urine so much. With liver disease, maybe that's not so apparent in the early stages, but things aren't quite right, and sometimes it's not very specific what's wrong with them. So those blood tests are usually really important to start off with, and then we'd go in slightly different directions depending on whether it's kidney disease or liver disease that we're looking at. So yeah, those blood tests, and the reason behind that would be why you wanted to kind of do that and investigate.
And you would look for both, wouldn't you? Most screening tests, you're going to be looking for both at the same time, because there will be some overlap of clinical signs. If they are presenting with a symptom, you won't necessarily know which one it is straight away, will you?
Yeah, so I guess in sort of older dog profiles that we do, we would have the basis of those would be urea and creatinine for renal disease, and looking at liver enzymes and the other things that the liver makes when we're looking for liver disease. So liver enzymes are a good marker of how happy the liver is, but the functional capacity of the liver really relies on the things that it does. So it makes protein, so albumin we measure, makes glucose, helps us with cholesterol management, manages the bile, so bilirubin. Those things help us with the function. The liver enzymes tell us about how annoyed the liver is. So they're slightly different things in terms of the function that organ has.
Yeah. And what other tests would you be looking at doing in addition to blood tests?
Yeah, so I guess it depends on the degree of elevation, and that's one of the things that's always something that we take in a bit of a pinch of salt. So if we're looking at kidney disease, we'll look at urea and creatinine, and there are other things other than true kidney disease that can elevate urea and creatinine. So dehydration will, to a degree, bleeding into the gut, irritation of the gut will cause urea to elevate as well. So if we're sure that that's the case, then we'll usually start with a urine sample, because looking to see whether the kidney can still concentrate urine is really helpful. If you've got good concentrating ability and you can make your urine really concentrated, the kidney's got to be able to work well, which is a good sort of screening test. And then from there, probably would look to potentially do an ultrasound to look at the kidney size and shape and the structure of the kidney. With that sort of chronic renal disease, you lose the size of the kidney, so it tends to get smaller, and the definition between the cortex and medulla, the outside and the inside of the kidney, tends to become less differentiated. So you can usually get a good idea as to whether there is chronic renal disease that's caused by the kidney itself not functioning, or there's a sort of obstructive type disease, or potentially infection, which is something we would pick up with the urine sample. I guess with liver disease, we would do the similar sort of thing. We would look to try and understand that. And I guess that depends whether we're looking for inflammatory liver disease, where we'd usually see the liver enzymes elevating, or whether we might be worried about functional liver disease. And if we've got sort of more advanced liver disease, usually the signs are quite a bit worse. But in those sort of early chronic inflammatory diseases, I guess we would do some functional tests. So we often look at things like bile acids, which are quite helpful to look at liver function. And then we'll probably want to do an ultrasound. And usually the liver there would be perhaps a little bit smaller. And the echotexture, so how bright or dark it looks on ultrasound, can be helpful in terms of trying to understand what disease process is present. But often we'll then want to take a liver biopsy. And whether we do take liver biopsies or not, there's a lot of discussion behind that. But ultimately, you can't really tell what's happening within the liver without taking a biopsy and having looked at it under the microscope. But usually we can have a good idea of what's happening and can make treatment recommendations in dogs that are mildly affected without needing to do that. In young dogs, we would often try to really be a bit more proactive, and that's usually where we would try and take biopsies.
Yeah. Just got a little question from Luke here about the values that on the bloods to do with the kidneys. So the BUN is urea, isn't it? That's the same thing. So some people call it BUN, some people call it urea. They're basically the same. And this SDMA, so we mentioned the urea and creatinine, and SDMA didn't used to be a thing until, I don't know, probably, how long ago?
Probably about, well, yeah, it's been used as a research tool for quite a while, but it's become much more clinically available, I guess, in the last 5 years or so.
So what is SDMA and how important is it, in your opinion?
Yeah, so you're going to ask me what the SDMA stands for, and I'm going to fail miserably.
I was literally just thinking that, Luke, I'd love to tell you what that means, and I should have prepared that because I knew it was going to come up.
Yeah, so I always get confused, but essentially both of them are markers of kidney function. So they're things that are produced in the body. So urea essentially is the breakdown products from proteins. SDMA is the same thing. It's a breakdown of arginine. So it's produced at a constant rate in the body, and therefore should be excreted from the body at a fairly flat rate. And so both of those will elevate if there's renal dysfunction. So if the kidneys aren't able to excrete it, then those values will go up. Usually we use creatinine. Creatinine historically has been the best marker. So it's produced in the muscle and gets filtered out at a fairly set rate. So if your kidneys aren't working, then it will tend to elevate. And historically, that's probably the most robust marker of kidney function we have. BUN, so urea, or blood urea nitrogen, tends to be affected by other things. So hydration status would affect that. So your BUN tends to be a bit less reliable if you're looking at kidney function. So I'd always choose the creatinine to look at, and then the BUN would probably elevate. And if there's any GI irritation or just mild gut bleeding or irritation would cause it to go up, and dehydration would also cause it to go up as well. Whereas creatinine, it tends to go up in quite a lot later stages of dehydration than the urea would do. So usually urea isn't that robust when we're thinking about truly trying to look at kidney function. So I'd choose the creatinine. The SDMA comes from looking at changes in kidney function before you get an elevation in creatinine. So if we're looking for chronic renal disease, as you're saying, you know, if we get to sort of 25–30% of renal dysfunction, then we're going to be starting to see that there's kidney signs and problems as a result of that. So we've always been looking for earlier markers to try and see if we can pick up kidney disease before we get to that kind of 30% mark. And SDMA is one of those kind of early warning changes. So it will elevate before we see elevations in urea and creatinine. So it allows us to have an idea that there might be a problem with the kidney function before we see more overt signs with the rest of the blood tests. So it's helpful in terms of picking it up. I think with all of those markers, though, it's really important that we understand that they're not necessarily reproducible, because there is biological variation. There's also analyzer variation as well. Yeah. So people get caught up with you know, very small changes with numbers, and that will change just on a day-to-day, minute-by-minute basis, just as what's happening in the body. And we compare them to reference ranges, which is, you know, where we should be in the ideal situation. And reference ranges are comprised of, if you had 100 normal dogs, where would 90% of those values be? So you always have some that are a little bit high or a little bit low, and variation within that normal reference range is normal. So interpreting liver and kidney values is always tricky, because you have to take all of those things into account. And often we look at trends rather than actually exactly where that number is, and how things are changing, and the reproducible nature of those values is often, you know, really helpful to understand what's going on.
Yeah, that makes perfect sense. I hope that's useful, Luke. So I mean, I think you were going to get tested again in a few weeks, Luke, anyway. So that will be the thing, really, just to see if those values are still a little bit high or top end, or how they've moved. So that's the most important thing here. So I hope that puts your mind at rest a little bit. So moving on a little bit towards arthritis. The two things to really think about here is how do kidney disease and liver disease directly affect arthritis, and then how are they affecting the management, which is what we're all here for, because most people watching this have got dogs with arthritis and are already at that point potentially where they're juggling the two things together. So are there things that can make each other worse? So arthritis making liver disease worse, kidney disease, or vice versa?
Yes, so a really good question. With kidney disease, perhaps not so much. It's something that we take into account when we're thinking about drug strategies and trying to sort of manage that kidney function as best we can, and putting treatment strategies in place for the renal disease, and trying to manage that renal function as much as we can. With liver disease, I guess it's a bit more interesting, because the liver sometimes is reactive to what's going on in the body. So if we have osteoarthritis, there will be inflammation associated with that. And because the liver filters that, we can see that there's a reactive change in the liver. So it's not unusual to see liver enzymes be a little bit elevated as a result of inflammation in a distant site, rather than the liver being the cause of the problem. So I think that's one of the things that's always really interesting. If you do sort of a geriatric blood screen on a dog, sort of 10 years old, maybe it does have arthritis, and you find that the liver enzymes are maybe twice what they would normally be, there probably is a little bit of inflammation in the liver. But that might not be because there's actually true inflammatory liver disease. It may just be the reaction of the liver to everything else that's going on in the body. So it's always one of those things that's really hard. And liver enzymes are a little bit of a tricky one when you're trying to interpret, because people get quite worried about those values. They, if there is inflammation, often they go really high. So talking 100 times the elevation of normal, if we're thinking about the reference intervals. So just small elevations often don't mean too much, and actually liver enzyme elevations don't necessarily reflect damage to the liver. It just shows the amount of inflammation that's there. So I think with liver disease, it's sometimes a bit more tricky to kind of understand what's happening with that in the early stages if you've just got mild changes, but it shouldn't make the liver disease worse if you've got osteoarthritis. So it's just trying to pick those two things apart sometimes.
Yeah, so just showing, like you were saying at the beginning, whether the liver is unhappy with something or just working a bit harder, as opposed to having reduced function.
Yeah, so I think they're two different things. That the liver having inflammatory disease doesn't mean that it can't function effectively. So the inflammation that's there, the liver enzyme elevations might not show any signs at all. So we have some dogs that have chronic hepatitis that appear completely well, and they have liver enzymes that are mild to moderately elevated, but actually the liver function is normal. So the liver can do absolutely everything that we would expect it to do, and can cope with things normally. It's just, if you look at the blood tests, you'll see that they're elevated, and there is a low amount of inflammation that's there. Effectively, those dogs are looking normal and feeling normal, and we're not seeing clinical signs associated with that.
Yeah, and there's another thing, well, a couple of things to bring up there really. Another reason to repeat those bloods and see if those values are repeatable or which direction they're going in, and also considering about the other diagnostics that you can use, like imaging, to have a look and see what the liver is looking like. So that's why sometimes when you go to the vets and if you've got slightly raised liver enzymes, it's not just simple, yes, you've got liver problems, no, you haven't. There's a lot more to think about. I think that's quite...
Yeah. And really stupid things like, we've sometimes seen dogs for investigation of liver enzyme elevations, and they're older dogs that have horrendous teeth and dental disease, and all of those sorts of things can feed into the reactive hepatopathies that we see. So sometimes you don't really realize that some of the simplest things can cause other changes in other places. It's not true liver disease, it's just the body reacting to something going on somewhere else. So yeah, it's important to look at the dog as a whole.
Yeah. I mean, the liver is quite a wonderful thing. It's just that sort of central organizer of the whole body, and it can do a lot, and it can survive a lot as well. So no, you don't need to... It's very easy, I think, when you've got an older dog and an arthritic dog and you're doing these blood tests and you're thinking, what are we doing them for? They're showing me this and I don't really know what that means, but they are useful, and they can give you directions to go in, but they don't always give you an answer straight off. So be kind to your vets, because they're trying to do the right thing and trying to help you find the answer to what you want to know. So moving on then more onto management of arthritis and how we're going to deal with that. What should we be doing? What shouldn't we be doing alongside, if you've got either one or both, even liver and kidney disease and arthritis?
Yeah, I think it depends on the stage of both those diseases and what the underlying diseases are. So obviously there's quite a bit more specific discussion to be had with vets about what the sort of individual circumstances of those things are. But with kidney disease, for example, we have the RS scale, which helps us kind of classify kidney disease in sort of stage 1, stage 2, stage 3, and stage 4. And dogs that sort of have stage 1, stage 2 probably don't have too many clinical signs. They're probably noticed because they've got slightly dilute urine. Their blood vessels, blood tests show that their elevations in creatinine sort of mildly. Those animals we probably would treat fairly normally for osteoarthritis. We would give them all the same treatment that we would do in normal dogs, but just keep an eye on things a bit more closely. So they'd be fine to have anti-inflammatories. All of the nutraceutical things would be fine. So the management in terms of their arthritis probably wouldn't be changed by that. We would put some strategy in place to try and help to minimize the work that the kidneys have to do. So changing their diet a little bit, reducing the phosphate component of that, making the protein easier for the dog to digest would be really important. And then just really monitoring really closely to see what's happening with the kidney function and what can we do to support that, and making sure that there aren't signs that are associated with the renal disease. So making sure there isn't progression in blood pressure elevations, making sure there aren't changes associated with protein loss in the urine, all of those things, just being kind of hyper vigilant that there isn't a problems. In more advanced kidney disease, I'd probably be a little bit more worried about introducing non-steroidals, and probably be paying attention just to make sure that they aren't sort of tipping the kidney over into not coping. But obviously the decision as to whether to use a non-steroidal or not in those circumstances is, again, a bit sort of cost benefit, because we know non-steroidals are really good at reducing inflammation, helping improve quality of life. But if there is underlying sort of severe kidney disease, then you perhaps would be a little bit more cautious about introducing it. But in the early stages and the low-grade changes with renal disease, we would be quite relaxed about treating it and just monitoring quite closely in that regard. With liver disease, I guess it's a bit trickier, because I think if you've got true liver disease, you're probably not wanting to use a non-steroidal, because you'll be treating the liver inflammation probably with a steroid rather than non-steroidal. And if you're doing that, you obviously can't use those two drugs together. So you'd have to think of other strategies, other drugs for the analgesic components. With low-grade liver disease, if we weren't using steroids, then non-steroidals probably would be okay. And again, we would use those and monitor closely just to make sure that there aren't exacerbations or changes. But again, all of the things that we would want to do for the management of osteoarthritis that we normally talk about would be reasonable to use in those circumstances. There may be other things that we do for the liver. So antioxidants would be helpful. We don't tend to use diet that much with liver disease. On the animals eat well, and I think that goes for the same for kidney disease as well. That there are lots of kidney diets, there are lots of liver diets, but with older dogs, it's much more important that they eat well rather than exactly what they eat. And that's the key thing. We can always make the diet a little bit better, but if you, prescribe a diet which would be the ideal and the animal doesn't eat it at all, then you're not going to make any benefit or have any sort of progression as a result of that. So I think in both circumstances, it's just being careful and monitoring and making sure that you're understanding the rationale behind the treatment that is being used. But in lots of circumstances, anti-inflammatories would be fine to use in those circumstances.
And how often, I mean, this is such an individual question, and it really depends on your vet, your dog, you, finances and everything. And there is obviously no set answer as this is what you must do. But how frequently, if you had a dog that was showing some changes on their bloods, how frequently would you recommend testing them?
Yeah, I guess it does depend on a lot of things, and by testing depends what change you found to start off with. I guess with renal disease, so Irish stage sort of 1 or 2, so mildly affected animals, we would probably follow the Irish recommendations for renal disease monitoring, which is every 3 months in stage 2. So I think that would be reasonable. If you were starting a non-steroidal, you'd probably do it after 2 or 3 months and just see what the changes were and make sure that everything's all right at that stage. With liver disease, probably depends what's happening. Normally, if we're starting an older dog on non-steroidals, we might take some blood after 3 to 6 months and just check that there isn't any change or concern as a result of that. I think if you had moderately severe inflammatory disease, you might take that after a few weeks just to make sure that there wasn't any exacerbation. But if that was fine, then to do it again every sort of 3 months or so and just check where we were. I mean, obviously that's the ideal, and we would perhaps be a little bit more proactive in cases where we were concerned, but sometimes you can just get away with just looking at the liver enzymes, or with renal disease, for example, just simply looking at urine concentration would be really useful just on a urine test and look at the specific gravity, which is how concentrated it is. And if it's really concentrated, then you probably be reassured that there isn't any renal disease that's there. So there are varying degrees of monitoring depending on what's happening in those circumstances.
Yeah, and I guess one of the other big things is the clinical signs. So if you start your dog on some medication and they start to drink more, or they wee more, or their appetite reduces, or anything changes, then the first thing we're going to do is probably take another blood and just see what's happened. Would you that's just a normal thing to do as well?
Yeah, absolutely. I think if we start medication and we see those sorts of reactions, then usually the reactions to anti-inflammatories would be GI based rather than necessarily kidney or liver based. But there are sort of rare reports of non-steroidals causing both kidney and liver disease, but they're quite few and far between. Some Labradors which are quite sensitive to non-steroidals, where they've published some carprofen toxicity that seems to be less apparent with other non-steroidals. So again, we're perhaps less worried about that. There are occasional cases where non-steroidals have caused acute kidney injury, but usually at higher doses, so their toxicity is really unusual to happen with doses in the normal range.
Yeah, I think, and they do get bad press, non-steroidals, and a lot of people say, oh, they caused my dog's kidney disease, they caused the liver disease. It's often not the case, but if you have concerns about those things, then just have a chat with your vet about it, and hopefully they'll put your mind at rest, or you don't use them, because thankfully we do have a lot of other options as well. But like Simon said, ultimately non-steroidals, they do what they say they're going to do, and they're really, really good. So you shouldn't just not use them.
Yeah, I think it's hard, isn't it? Because it's one of those things where there is some evidence, and there's published literature that suggests that there is a link between non-steroidals in certain circumstances for both kidney and liver disease. But most of the time, we're looking at a population of older dogs that have these kind of underlying subclinical diseases that are quite hard to spot. So our blood tests are only finding kidney function disorders where we've lost upwards of 70% of kidney function. So we could take bloods and they're absolutely normal, and you're in that sort of 70% function. And then over time, we're going to see that those elevations are going to go up because of normal progression of that underlying disease. So often it's really hard to tease apart whether this is drug related or not, or whether it's just progression of an aging change or something else that's happening that's there. So I fully understand why owners get concerned about those things, but a lot of the time it's really multifactorial rather than it's a direct effect of the drug.
Yeah, absolutely. And there's a couple of questions up here about the non-steroidals. Lynn's just written one here actually. So some owners are concerned about liver and kidney issues and are fearful of NSAIDs, arguing for something more natural. Some use CBD, but there has been evidence, Lynn, look at this, that can raise liver enzymes. Is that with the CBD you mean? Should these owners have regular testing for liver, kidneys in much the same way as those on NSAIDs?
Yeah, it's interesting, isn't it? So I guess CBD has been used for lots of these kind of conditions, and I think has a place in terms of management if other things haven't worked. I guess there's a lot that we don't know in terms of how that works and what effect that has on liver and kidney function. I think they're probably reasonably safe to use in those instances. I don't think they affect kidney function very much, but yeah, there are some rare reports of what we call idiosyncratic reactions where drugs are thought to cause inflammatory disease. Another long-standing word for we don't really understand why that's happened. But yes, that does seem to be something that can sometimes occur. So yes, it would be sensible to do some monitoring if that's used as part of the mainstay for management in those sorts of circumstances.
Yeah. I just wanted to touch a little bit more on the diets and just reiterate what you said about the dogs can have these prescription diets, and they are really useful, more so in kidney disease. But actually, if you have got a painful dog, and hopefully you haven't, because hopefully it's well controlled, but those are the ones where appetite is going to be even more reduced, isn't it? So you do need to consider using diets, but don't put all your money and all your hopes on the diets controlling them, because it is better for the dogs to just keep eating one way or another. Which diets would you, or which dogs do you recommend diets to? When you have an arthritic dog come in, how much time do you spend on talking about those diets?
For truly arthritic dogs, or when we're thinking about dogs that have concurrent
with concurrent disease, yeah.
Yeah, so I guess they're slightly separate things to kind of consider, aren't they? So I think when we're thinking about renal disease, we know that moderate protein restriction and phosphate restriction do help to improve things in the longer term. So there's quite a lot of evidence that those things help to reduce the decline in kidney function. So if you can get a dog to eat a renal diet, and that can be, just thinking about the wet foods or the dry foods, there are lots of different foods that could be made. There are some home cooked diets, so you can choose whatever combination of food you want that has the same intention of doing that. That would be the ideal in that respect. If we can reduce the protein content to make it more easily digestible, has less nitrogen associated waste with it, so the urea bit that we're talking about for excretion, and reducing the phosphate, because we know that phosphate excretion, if we're asking the kidney to do more of that, will affect the function and can cause further damage. So we do try to restrict those, and I think that those would be the most important bits for sort of renal disease. If the dogs won't eat those diets, then we want them to eat, and I think that's the most important thing. If we've got older dogs where they've got less muscle bulk, they've got underlying renal disease that's making them feel unwell, then feeding them something that they'll eat so that they're getting the calorie content, the protein content to maintain their body condition is really important. And there would be other ways that we could potentially look at managing things like phosphate, using phosphate binders that would potentially be helpful. So often we have a bit of a trade-off. So you sort of start at the ideal and then you sort of work back from that. And I think the renal diets in those instances would be really important. But if we have a dog that's fussy, or for whatever reason we're choosing a diet that we have to make, or we have to construct for different things, or there's underlying gut disease that means we can't feed various components of the diet, then we'll often compromise and we'll use other things to try and have the same effect by limiting the protein a little bit and restricting the phosphate. And sometimes that may be just as much as using a lifestyle diet, because the dog foods that are designed for geriatric patients or older patients do tend to be a bit protein restricted, they're phosphate restricted. So the same sort of ideas go behind that. And so it may be that we kind of trade that off a little bit in terms of getting the animal to eat more effectively. So I think from the arthritic patient with renal disease, that's where we would be going with things, but then thinking about the management of the arthritis as a separate condition with that. And a lot of the things that go with inflammatory joint disease also go with sort of inflammatory kidney disease. So if we're thinking about essential fatty acids and all those sorts of things, that can be in terms of managing inflammation in the kidney and potentially joints as well. So those things would be useful. We don't tend to use liver diets until we get to kind of quite late stage liver disease.
Right.
So the intention with liver diets is usually when we have patients that have what we call hepatic encephalopathy. So it's quite a late stage where we're trying to see that we can manage the liver function by reducing the protein quite significantly. So that's usually where the liver can't cope with the functional bit, so it can't detoxify the food very well when it's been eaten. So then we would restrict protein quite severely. We would try to give calories in the form of fat and carbohydrate. Which isn't something that's suitable for dogs unless they get to that stage. So liver diets are really only used in those very sort of specific circumstances and late stage disease. So we wouldn't normally be thinking about a liver diet for every single dog that has disease. There are some specific circumstances. So we know that, for example, copper can be a cause of hepatic toxicity. So copper restricted diets would be something that we'd be thinking about. But in those instances, I guess diet is perhaps less important. But for renal disease, it's definitely something that we need to try and manage if we can.
And what if you had a dog that was already on a mobility diet, like one of the prescription mobility diets? What would you prioritize, with the renal diet or continue with the mobility diet?
Yeah, I think it depends on the situation, doesn't it? And I guess if that's the one thing that's made a difference to that dog, then perhaps we compromise in other areas. So it is exploring the options and trying to see what's there. Diet for kidney disease is a long-term thing, so it's something that's going to make a difference over many months. It's not going to be something that makes a difference on a day-to-day basis. So it depends on the severity of the renal disease and what the long-term benefit of that is. So by feeding it over the course of a couple of years, are you going to slow down the renal disease to maybe give you a few more months at the end of that period? Or if you've got really severe kidney disease where actually the dog is quite severely affected and the mobility is an issue, then actually changing his diet probably isn't going to make a huge amount of difference. So it's all really about the quality of life and the trade-off between the changes you make and the benefit that they have. So I think it's quite difficult to answer that question without sort of having the specific circumstances, because one dog, it may be appropriate to continue with the mobility diet and potentially think about other ways of managing the phosphate a little bit. And in another dog, it may be that after discussion and working together, you decide that you do change the diet to a renal diet, and that might have a benefit for that patient. So it's not that there's a right or wrong there, it's just understanding the differences between those approaches.
But it's good conversations to have with your vets, and just to have that confidence, isn't it? Just to make sure that you're doing things for the right reason. Because I think some people will come in and they will maybe with the end stage kidney disease, they'll be very aware that time is not on their side, and they do just want to keep their dog happy, and so they're going to basically give them whichever one they're going to want to eat, or probably neither of them, and just feed them whatever they want, full stop. And that's fine. It's not with any of these diets, but especially with renal disease and arthritic disease, they're both going to progress no matter what you do. You can't reverse either of them, so you just have to take each case as an individual. I think that's a very good answer. Thank you. And just moving on a little bit, we've kind of touched on this already with the supplements. So a lot of dogs are on joint supplements. And I think you already said that there's no need to be stopping those if you're diagnosed with either kidney or liver disease. Would that be right?
Yeah, I'm not aware of any evidence that either of things like chondroitin, glucosamine makes any difference to the progression of renal or liver disease. So we'd be very relaxed about giving them. I guess the only concerns when we're giving things like that is that if they're difficult to give and they're putting dogs off eating, if they're in latter stages, then that would be something that we might drop and leave out. But they make a difference to quality of life and mobility, and not really affect the underlying disease process. So we would usually be quite keen to continue them.
And then there are a few questions have come up that I've noticed about liver supplements. So some people I think have mentioned before, when they start their dog on non-steroidals, should they just be starting them on a liver support anyway, even if they don't have any signs or blood changes to do with liver disease? Should we be looking into that? Should we be starting them on something like Denamarin or whatever?
Yeah, so an interesting area, because the evidence around the use of supplements for liver disease is quite weak. We use a lot of liver supplements, so a lot of those would be quite natural things like Silymarin, which is milk thistle, or SAMI, so another antioxidant we use quite often, or vitamin E, which is again another very good antioxidant. And those things are thought to be protective to the liver a little bit, and we have some evidence from some toxins. So there are papers with mantidine mushroom toxicity, where that's a toxin that causes the liver quite a lot of damage, where those antioxidants are protective. They limit the amount of damage that's there. We know that they limit the damage caused by some chemotherapy drugs as well, with lomustine, and they tend to be helpful. but we don't have a huge amount of evidence for things like non-steroidals or other things that might be low-grade toxins. We do know that they don't really cause any harm. They're quite safe medications for us to use, so that they're maybe helpful to help the liver to adapt and to overcome things. So I don't think it'd be wrong to use Denomarium when you're starting a non-steroidal for the first time, but most people would suggest it's probably not necessary to do that.
Yeah, and that goes for, like you said, with any medications that you're going to be starting on, because a lot of the medications, I know non-steroidals have the biggest press and the biggest issues reported about them, but we use a lot of other analgesics now for arthritis, and most of them, Brella will touch on maybe, but most of them are going to need the liver to do something to metabolize them, aren't they? All of these drugs that your dogs are on.
Yeah, so I guess there's a spectrum from things that the liver can cope with quite easily to the liver really can't if those sorts of circumstances. So paracetamol, for example, with liver disease for me would be a big no. Yeah. It's metabolized by the liver. We know it causes hepatotoxicity. So that if we had liver disease, we would be trying to use different drugs in different ways and avoid things where there were potentially upregulations in metabolism as a result of that. So that there's kind of scale of badness, I guess, in that regard when you're sort of thinking about things that cause a problem. But how far you go along that pathway depends on the quality of life and the long-term outcome that you're looking for. So sometimes we will do something that has a bit more risk if we feel that the benefit is going to be better. So it's trying to weigh up two things.
Yeah. There are some drugs that you wouldn't necessarily use with liver disease, like the paracetamol, but you might want to choose that if you had kidney disease. It may be something that you would choose to use. So that it's not sort of a yes, definitely no for that drug for an osteoarthritic dog that has any other concurrent disease. It's everything. Every case is going to be different to whichever drugs. And we're not going to go down the route of saying use this, and this for kidney disease, and this, and this with liver disease, because that's a conversation with your vet really about how to manage the case.
Yeah, veterinary medicine's a bit of a mystery sometimes. It's about building a picture, so putting all the bits of jigsaw puzzle together. And unfortunately, there isn't a recipe-based solution to every situation. So it's really finding the right answer is for every individual owner and pet, and kind of compromising if you need to.
Yeah. I know Hannah said this before as well. Just because you can do these things, and this is just because this would be maybe the best way to manage on paper a dog, it doesn't mean that that's going to work when in practice. So when you have the dog in front of you, there are going to be lots of other factors that mean that you might not do that plan that would be perfect on paper. And you shouldn't ever feel like what you're doing is the wrong thing, because every case will be different. So it's
absolutely. It's finding the right thing. Yeah, exactly. And just because you can do something different, or there are additional tests, or there's a really expensive medication or something, if what's working is working, then don't change it and find what works for you.
Yeah. And it goes without saying, obviously we're CAM, so all the other things that you can do at home that are non-prescription, non-vet things, so all of the lifestyle changes, all the home things that you can do at home are the same. If you've got liver or kidney disease, you can still put rugs down. You can still stop throwing the balls. You can still stop going upstairs and get ramps for your cars and everything that we talk about that everybody's probably sick of hearing, that you all know, that you dream about. All of those things are still very, very valid for these cases. So don't forget those. Don't just concentrate on the medications. Lots of stuff around it as well. Is it okay if we just go through some of these questions before I lose them all? First of all, SDMA, symmetric dimethyl arginine.
Well done.
Thank you, Casper. So we have here, Julia, I think this is quite a touch on this one. So what analgesics are safe to use for dogs with CKD and arthritis? Have a really good chat with your vet and talk about what you want and what they think might work. And it really depends on how severe, how long, how your dog is with the CKD as to what you're going to choose to use. Would you agree with that?
Yeah, I think so. It's really trying to work out what the right combination is. So the newer coxibs that we have, things like fibrocoxib and so forth, are really safe with chronic renal disease. But it depends on other factors. For example, if there's hypertension associated with the chronic renal disease, then we'd be more cautious about giving them, maybe worry about the gut if side effects a bit more and those sorts of things. So Yeah, safety is one of those things that's really difficult, because nothing we do is 100% safe. You know, just walking alongside the road isn't 100% safe because you don't know what's coming along. So yeah, we can use the safest drugs with the lowest risk, but we have to sort of understand where those risks come from. And most of the time, they're very small within the context of the things that we're talking about. But that's why we're talking about monitoring and looking for changes, because if there are changes, usually there'd be something that we're going to be picking up, and then we change the strategy. We don't continue with that. So yeah, I can't say that anything is safe, but there are better options and there are not so good options in that regard.
Yeah, and your vets will know those. Yes, the liver enzymes would be raised. We just said this sort of earlier on that the liver enzymes are ALT, or two of them are ALT and ALP, and they can be raised through osteoarthritis inflammation, but it doesn't mean that that's definitely what it is if you see it on the blood. So it's worth retesting and just monitoring those situations.
Yeah, so in answering that question, it would normally be the ALKP that would be elevated in reactive disease, but the ALT can go up as well. So they're two slightly different liver enzymes. So ALT tends to be within the liver cells, and the ALKP, so the alkaline phosphatase, tends to be on the outside. So it's more associated with biliary disease. So often, if we're seeing reactive hepatopathy, you'll see the alkaline phosphatase go up a little bit before the ALT, but it's one of those things that is really hard to tell what's going on. But normally you wouldn't expect reactive hepatopathies to take your liver enzymes above kind of 4 or 5 times the reference interval, which is kind of how we sort of stratify the differences between those. So the reference interval for ALT and phosphate between, depending on the hours, I guess, between 0 and 100, something like that. And so it's the multiples of that 100 that we're looking at to kind of see. So they should be below about sort of 400, I guess, for reactive hepatopathy. And if we sort out what the problem is, so we start treating the osteoarthritis or sort out the dental disease, then they'll go down as a result of that.
I mean, the other thing to think about with liver enzymes is that there are so many things that can cause them to go up, and lots of, in older dogs, even more conditions. So you've got all the endocrine conditions as well that you're thinking about. I'm sure a lot of dogs are also suffering with Cushing's or hypothyroidism, and all of those things can have an effect on the liver enzymes as well, can't they?
Yeah, huge number of things, and that's, I guess, one of the things that liver enzymes and the elevations of liver enzymes is a huge sort of topic in itself, but it doesn't have to be because of true liver disease. So you have to take a look at the whole picture, and that's why we would want, that's why vets take good histories, that's why they do clinical exams, that's why we spend a lot of time looking at that sort of detail to see whether those blood results fit with the clinical picture. So if you show me some blood results from a dog and say, what do you think is going on, what should we do, then that's only one really tiny part of a huge picture, and you can't make any judgment just on the basis of those results and those numbers, and those numbers without all of their context and everything else that's happening are quite meaningless.
Don't mean much.
Yeah, exactly.
Just going to show this one here. So from Jeanette, my late lab had arthritis and spondylitis. She took Rimadyl at first, then her liver enzymes went up. We got them under control with Denamarin, and she was then diagnosed with acute kidney disease at 11.5. We managed both conditions as well as we could, and she made it to nearly 13. Did repeat bloods often. I remember albumin levels were really low at the end. That would make sense, I guess.
Yeah, we're sorry to hear about your dog. I guess the albumin there would be low for potentially a couple of reasons. We know albumin is made in the liver, so if the liver is struggling, then the amount of albumin that you have a blood protein is going to be lower than you'd expect, and that can cause problems because albumin is responsible for keeping all the water in the vasculature. So if you have low albumin, you tend to get sort of puffy limbs and what we call ascites, so fluid in the abdomen, so you get sort of pot-bellied appearance. But it can also happen in renal disease. As that disease progresses, you'll lose albumin through the kidneys as well, and protein present there can further damage the kidneys as well. So I guess there would be 2 potential reasons why that might occur.
It sounds like you did really well, diagnosed with the kidney disease as well at 11.5, and still went on for another 1.5 years. So you did amazingly to manage that however you did. Well done you, and well done your vet as well. I have had bloods. Says, I have had bloods done on my 10-year-old healthy dog, so we have a baseline. Should I consider this for my 6-year-old dog? Kind of, I guess it's always a nice thing to have that information. What do you think?
I think it's really hard, that sort of question, in terms of, I think sometimes you have to know why you're doing the test to what will you do with the answers that you get from that test, and why are you doing it? So I mean, 6 is quite young still, really. So I'm not.
Depends what breed it is as well, I suppose.
Yes, yeah, I guess, yeah, it does depend what breed it is, but yeah. So I guess if you're a giant breed dog, then maybe that's a little bit further on than perhaps it would be for a smaller breed. But I think you sort of getting nearer to 10, and sort of at that age, you perhaps be thinking about maybe doing some screening bloods if you're concerned about things, or if you were starting medication. So if that 6-year-old dog had arthritic signs and you were thinking about starting medication, then I probably would do that as baseline to see where you were with things. So I think it depends on the rationale, but I think just testing because we can probably, without a reason for doing it, I think perhaps it's a little bit trickier. So I think you have to understand what the results are, because it comes back to reference ranges as well. So you'll get 90% of the results in the reference range, but by chance 1 in 10 of those results will be a little bit outside, and then you can go down
nothing to worry about.
Yeah, exactly. Over-interpreting those results and worrying about things that are actually normal because you've just done those tests. So it's really important to understand why you're doing it and what you would do with those results.
I mean, I think I've had one client quite recently actually ask me about X-raying a younger dog just to get a baseline of what their joints look like, and that again, you think, well, yeah, we can do that, but we know arthritis isn't always obvious. There are little things that can not be obvious on X-rays, and actually, what use is that of those X-rays going to be for us right now? And probably not very much. So I think it goes, I think it depends. If you're worried, and if there's been any disease in the family line, then maybe you would do it as well. But yeah, otherwise, chat to your vet if you want to do it. I'm sure they would be willing to. Here's a question from Becca. My boy Chulo just underwent surgery for multiple mass surgery. His blood work showed elevated liver enzymes, so an ultrasound was done. Gallbladder sludge was found. He's already on a low-fat diet and takes omeprazole, mantidine, gabapentin, along with laser and acupuncture weekly. Is there anything else I can or should do for him? Repeat the blood tests regularly?
Yeah, so I guess there's a couple of issues there. I guess first thing would be what the liver masses are. So I guess making sure we understand what they are, that they be a huge spectrum from benign things with liver masses as dogs get older, so benign nodular hyperplasia and those sorts of things which aren't too much of a concern, through to things that are a bit more sort of worrisome, and hopefully your vets have been able to remove everything there that's causing a problem.
I think multiple masses may, I don't know if I'm interpreting this differently, but I think they might just be more like skin masses, lumps.
Okay, that's fine. So we still send them for histopathology and understand what they were. The gallbladder sludge is a slightly different issue, and this is one that we've never really got to the bottom of. Gallbladder sludge doesn't necessarily mean that there's anything wrong. So I guess when we're looking at the gallbladder, normally you'd expect to see it's a bit like a balloon. It fills with bile and then it empties when we eat food, and so you have it there to help emulsify fat, so it makes absorption of fat a bit easier. But in older dogs, we can find that we find a sediment there. So it's sort of what's described as sludge, which isn't really thought to be that significant. That the sludge in itself isn't really something that we tend to worry about. The concern kind of comes from the progression of that to more solidification of that sludge into what we call sort of a biliary mucocele, which usually means that we need to do surgery to remove it because the gallbladders become solid. But the sludge in itself doesn't necessarily mean that there's going to be progression of that disease. So usually we keep an eye on it and repeat the liver enzymes exactly as you said would be the way forward. If we're concerned, then there are things like ursodeoxycholic acid, distillate that would be helpful in terms of helping the gallbladder to contract and maybe potentially remove some of the sludge. But there are a couple of studies, we did one in conjunction with Cambridge over the last few years, just looking at the progression of that sludge, and you find you're just looking on a different day at the gallbladder being a different size with slightly different percentages of sludge that's there, and actually very few of them progress to actually be a clinical problem. So again, we'd normally be relatively relaxed about sludge in the gallbladder, but it's one of those things that we keep an eye on every so often, so maybe every sort of 4 to 6 months, rather than would be something that we proactively try and treat.
Okay, that's interesting. I never really thought about that. Here we got my dog. This is Julie. My dog has hepatic masses and stage 3 CKD. She has a high serum calcium and high phosphorus. We have been prescribed Phosphoenol. Have you ever prescribed this, and has it been successful with side effects?
Yes, so phosphoenol is a phosphate binder. So it goes back to what we were talking about before when we were saying dogs that couldn't be on a renal diet to try and bring the phosphate down. I guess we're concerned here because calcium and phosphate both being high lead to calcium phosphate deposition, and that's why we try to reduce the phosphate. Firstly, the phosphate can be problematic for further damage to the kidneys, can damage red cells, but also if the calcium is high because it's not being excreted, it will cause calcification of various body organs, and that further worsens the kidney function, and that can cause issues in other places as well. So we do tend to bring the phosphate down. So yes, I have used it. We've got a variety of different phosphate binders that we use. I mean, historically, aluminium hydroxide has been the most effective, and the newer ones, they do work. I guess we don't have good studies that kind of compare how well they work. I'm not sure what the comment was about the side effects.
Yes, sorry. The side effects. Has it been successful with the side effects? I'm guessing of the renal disease, of the CKD.
Yeah, so I mean, it's helpful in terms of bringing the phosphate down. It's one of those things. It's quite hard to. You won't necessarily notice that there's a difference if you bring the phosphate down. So it's often hard when you're thinking, renal diets, or if you're thinking about phosphate binders, you don't necessarily see what the benefit is when you're giving them, but you see that over time that there is less progression as a result of that. So it's one of those things that's a bit tricky. It's like you're not going to be curing the problem because you're giving the medication, so you might not see that there's actually any change, but you're helping the kidney out and helping to limit the progression of that problem. So yes, it has been successful when we've used it, but yes, it's kind of a longer term strategy rather than something that will make an immediate difference.
Another one here, Heather. My CKD arthritic dog won't eat renal foods. That's fine. Is there anything more palatable? So basically, what would you suggest home cooked meal wise? What are we looking for with low phosphorus and good quality, easy to digest proteins? Just eating mince and mash or chicken and rice, but probably not ideal for the CKD.
Yeah, I think it's difficult, isn't it? It's one of those things where you're kind of balancing quality of life against where you are with things. So in the latter stages of renal disease, that'd be absolutely fine. But in sort of earlier disease where you're trying to sort of help to improve and support things and really trying to minimize the impact on the kidneys, I'd have a chat with your vets, and there are loads of veterinary nutritionists that are available to give advice on what the best combination of things would be. So we use them quite a lot, and there are ones that can do that just on the internet, provide your vet with help and support to be able to do that. So in terms of both being able to provide advice about commercial diets that are available for certain circumstances, if we've got combinations of disease, so gut disease and renal disease, they're really useful. Or if there are limited things that the dog will eat, then we can use those to build a diet that is balanced and would be better in the longer term. So yeah, mince may be a suitable component of that diet, but in small amounts, and how we build the rest of the diet around that would depend on what the dog is eating. So the consult with a veterinary nutritionist would be a good way of starting that, and there are a few people that would be able to do that. So there isn't, again, one size that fits all, but if you're feeding those diets in the longer term, balancing the vitamins and minerals, especially the phosphate and the calcium there, would be really important. So looking at the components of that and how we build that at home would be really important to make sure we've got it consistent, and that it does sort of tick all of those boxes. It's very easy to get it wrong if you're not balancing it properly.
Yeah, and I think probably this is one for a nutritionist as well to answer, but there was a question about is U-Move high in phosphorus because it's what's here, all crustaceans. So sorry, somebody has written here, I switched to Riflex from U-Move as it's lower in phosphate. I'd contacted both companies for an analysis for their products, and this one was better. Would you say talk to a nutritionist about that as well, about how much phosphorus are in these supplements? Is it like it's not likely to cause a problem?
Yeah, I guess it's difficult, isn't it? Because a lot of these things will be as the phosphated component of the active ingredient, which is what we want to try and reduce in terms of the amount of phosphate that's there. For me, the amount is probably not a particular problem, but yes, okay. I'm not completely up on the different commercial products, unfortunately.
No, nor am I, unfortunately. But I think nutritionists would be able to look at the package, look at the details, the ingredients, and hopefully help formulate if it's going to be a problem or not. Would you? So yeah, that's that one, that green lips muscle one. Here's a good one from Julie again. Shivering. How can I tell if it's pain from arthritis or effects of CKD? Probably can't.
Yeah, I guess you can't. This is a kind of the James Herriot question, and trying to understand what's causing the problem. I guess it's interesting that the renal disease in itself isn't inherently painful in the sense that because you've got reduced kidney function, smaller kidneys, that they shouldn't be painful. But some of the effects that we get from the latter stages of renal disease can be painful, especially if we get build-up of uremic toxins, irritation to the stomach, the mucous membranes, and those sorts of things. So those could potentially cause pain that's not easy to spot, but usually that's quite advanced renal disease, and we would probably know about that because of other reasons and not clinical signs that were there. So I think it's probably more likely to be arthritic disease than it is to be a result of chronic kidney disease, but it's quite hard sometimes to tell. Shivering is one of those things that's a little bit odd and can happen for lots of reasons other than just painful things. So depends when it's happening and to understand why it's going on. Yeah, but I mean,
you may want to initially look at your pain management and look at all the other pain indicators to see whether it's more likely to be the pain, and see if we can improve the pain management, and that affects, hopefully will reduce the shivering, and then get a better idea of whether it's due to pain or not. And this one just here. This is from lovely Lynn. We have annual screening bloods as part of a comprehensive health assessment every year, irrespective of other blood tests. Hypothyroidism for our girl, OA for our boy. We've done this since we adopted them before they were 3 years old. It helps that they love going to the vets. Yeah, I think it's fine to do, but like Simon said, it kind of depends why you're doing them. And if it is just to know that everything's fine, then there's no harm in doing that. One more. So that was about that one. If we had here we go, from Sheila. If we had a good SDMA and ultrasound in September, had a reaction to Previcox, ultrasound of the kidneys, I'm guessing, would it be probable her current BUN and creatinine elevation is CKD? Would her kidneys decline that much in 4 months? Doc is 11 on gabapentin and fluoxetine. Previcox was 9 days, switched to galliprant for 2 months, and now Librela. So if we had a good, so Sheila, I'm not sure if I'm getting this right, but she currently has a raised urea and creatinine, but previously in September, I'm guessing her BUN and creatinine were normal. If you can clarify that. I mean, you certainly would her kidneys decline that much in 4 months? You can get changes on kidneys quite quickly, can't you?
Yeah, exactly. I guess that's tricky to know because that progression of renal decline, you can get a normal SDMA, but you're still on that decline. So that can happen that quickly. I guess we could see you've got a normal result, and then over 4 months that's progressed.
Sorry, they were elevated in September as well. The UN and creatinine, but the SDMA was normal.
Yeah, I think that sort of goes when you're building a picture of renal disease, that you don't necessarily always see that all the markers are elevated. So with the creatinine being elevated and the SDMA being normal, there's still significant renal dysfunction at that point because the creatinine is elevated.
Yeah.
So that sort of suggests there's a progression of that over time rather than it's been caused by specific change. And the ultrasound, I guess, it's you can have significant renal dysfunction, but the kidneys look normal on ultrasound. So when we're doing ultrasounds of kidneys in that regard, we're looking for structural changes that help us to treat things differently. So we're looking for obstructive disease, we're looking for evidence of infection, we're looking to try and help us to understand whether the disease process is right or not. And you see tumours and other things that cause problems. So that could be normal and still have significant chronic renal disease. So yeah, I think it sounds like there's progression of the disease there, and yeah, we can see that happens quite quickly.
It probably would be worth getting a urine sample in to your vets if they haven't already done that as well, and just starting using that as a monitoring process as well, just alongside the bloods, just to get a bit more information. Would you agree?
Yeah, I think it's really useful when we were talking at the beginning about urea and creatinine and hydration status, then you can't really interpret those results without knowing what the hydration status is. So you do really need to have those blood results as well as a urine sample to interpret what's going on. So I think, when we're thinking about screening profiles, if we're thinking about geriatric dogs, then that for me probably would be to do the biochemistry, so the blood test, but to have a urine sample as well. And again, that helps you then to interpret the significance of those results. If you've got a really good concentrating ability, so the kidneys are working really well to retain water, but the urea and creatinine are up a little bit, well, that may just be because the dog went for a long run and didn't drink enough before it came in. So it helps you to build a clinical picture to understand that. So urine samples are really important.
I think that's it. And Julie's just put at the bottom, which is a good thing. I was thinking about this earlier when you were mentioning about Iris, that we should put a link, and Julie's just put the link in here in the blurb, but I will put it after the live as well, because the Iris staging website is really useful. It's got a lot of information. I probably use it on a daily basis between dogs and cats for looking up stuff about renal disease and recommendations. It is really good. So I will put that link up afterwards as well. Just one last question from Luke here. This is the Brella kidney safe?
I wouldn't be particularly worried about using it. I think it's one of the things that we would sort of class as kind of trying to be careful with monitoring. But again, I think it's like, well, it's sort of everything. We don't overtly think that there's a problem, so I would be careful with monitoring and just make sure that we're understanding what we're doing. But again, it depends on the dog, but I would be happy to use it and just to monitor. It's balancing quality of life against the potential risks. So as I said before, I can't say it's completely safe, but I'm not sure I have a huge concern about using it in those circumstances.
It's still a very new drug as well, and there's lots more going to be coming, as we use it more. It may be one of those things that, because a lot of dogs that are having Librela are the older ones that may have an underlying disease process, and then when you're testing 3 or 4 months later, that disease process just becoming more evident anyway, whether you'd had Librela or not, or with any medication. It doesn't have to be that. It can be anything. So we can have another chat about that another time. But I'm very aware that The Apprentice has just started at 9 o'clock, and that some people might want to watch that as well. But thank you so much, Simon, for joining us. And thank you, everyone, for all your great questions. And hopefully it's been really informative and cleared up some of the things that pop up quite often in Holly's army. And I know it's a huge concern, and it should be. And everyone's doing a great job with what you're doing. So keep doing well, keep coming and seeing us, and have a good evening, everyone.